Hi, I'm Jess Morley. I'm a postdoc researcher at the Yale Digital Ethics Centre. Before I was here, I was a DPhil student or a PhD student at the University of Oxford, and before that I used to work in the Department of Health and Social Care. So all in all, I have been around in NHS data policy, NHS digital policy, NHS tech or AI policy for around about 11 years. And this is a presentation about designing an algorithmically enhanced NHS, or how do you get AI to work in the NHS. So first off, why do we, in this case policymakers, want to deploy AI in the NHS? The fundamental reason, or the primary reason, is that the NHS is in crisis. I probably don't need to tell you this. If you have paid any attention to the news, or if you've been a patient, or if you are indeed a clinician, you will know that the NHS is essentially on its knees. There are a multitude of reasons for that, some of which are more political than others, but the most salient reasons as to why the NHS is currently in crisis for this particular discussion is that we have more complex patients, including many more older patients, including many more people living with comorbidities. We have more complex treatments, including more targeted treatments. As a consequence, we have skyrocketing costs, and yet we have diminishing returns. Again, there are multiple data points upon which we could draw to highlight those diminishing returns, but the clearest and the simplest is that we have a declining life expectancy in the UK. According to policymakers, the solution to this, or at least how it is expressed in policy rhetoric, is that by using data and AI, we can make medicine more predictive, preventative, personalised and participatory, P for medicine. This will make it possible to intervene earlier, so to determine when people are going to become sick, what they are going to become sick from, and then to intervene and to give them treatments that are targeted to them very specifically based on their genetics, based on their living experiences, based on every single thing about them, in order to achieve better outcomes. And so by intervening earlier and giving people more tailored or personalized treatments that are designed to produce better outcomes in them specifically, we can make care more proactive rather than reactive, and therefore achieve the so-called triple aim, the idea that we can simultaneously improve the experience of care, improve population health, and reduce per capita cost. My caveat is that I don't think that is achievable. We are much more likely to result in a wonky triangle where we achieve one or two of those data points. But my opinion and caveat aside, this is the rhetoric that is flowing through policy at the moment. This is how we deal with the fact that we have complex patients, complex treatments, skyrocketing costs and diminishing returns, is by relying very heavily on P for medicine through the use of data and AI, and therefore achieving the ultimate ambition being that by doing that, we create a learning healthcare system. This is the idea that data is flowing around the system the whole time, and we are therefore able to see what treatments work, what treatments don't work, what treatments work for what particular types of patients, what services are needed, what services might be needed in the future, how well are they working, and we can take all of that information and make it available to clinicians at the point of care so that they can make very tailored, very personalised, very predictive recommendations to their patients, and then we can look at how those outcomes work, and we can rethink through how the whole of the NHS is working according to those constant monitoring of the metrics. So to just put that in a little bit more precise terms, step one is you take real world data that is recorded in a clinic, so for example when a patient is treated or diagnosed. Step two is those data are used to train computational models that lead to new understandings of disease, and in particular its underlying causes. So we take a bunch of data, we throw a model at it, and we say go and find the patterns in that data. Who is most likely to get sick and why, and how are we most likely to be effective at producing better outcomes in them, i.e. how should we treat them in a personalised manner. If you want to go and do more nerdy reading about that, it's a concept called systems medicine. Step three is that new understanding is translated into tools in the clinic to help clinicians advise patients at the point of care on how to prevent disease. So all of that information about all of the people has been used to train computational models that have told us that these factors are associated with these types of disease. These patient who is now in front of the clinician matches these conditions of the people who are most likely to become sick. We know that those people who become sick of this particular condition see good outcomes by taking these preventative steps, 1, 2, 3, are now going to present that information to the clinician, for example, in a pop-up at the point of care, so they can tell their patient what to do in order to prevent them from becoming sick. Then, step 4 is the outcomes of all those preventative interventions are also recorded, so we know that when this specific advice was given at this point in the care pathway to a patient that looked like this is what happened. That's fed back into new computational models, so the idea is that the system is learning the best way to treat these types of patients in these types of conditions, and then we may update, for example, NICE guidelines, and that goes back into the system from the beginning and the whole process starts again. Or to be really precise, via data-driven feedback loops, the aim is that the NHS can learn how to most efficiently produce the best outcomes and so become more efficient, more effective and more sustainable. And ultimately more evidence-based, because we are building on real-world evidence all the time, less wasteful and less harmful. Don't just take my word for it though. You might just think I am being facetious and making up this rhetoric. I am not. I will give you 4 examples. So example number 1, from Saving and Improving Lives, the Future of UK Clinical Research Delivery, you see here, our vision is for the UK to become the most advanced and data-enabled clinical research environment in the world. Then we have the future of AI for health and social care. This was the draft NHS AI strategy. It never saw the light of day. It never became a real strategy, but it sat in draft form for a while. This is probably the most explicit. It says by 2030, the UK has a learning health and care system delivering better outcomes for the public, enabled by the effective use of safe, ethical and effective AI. Example number 3, from the life sciences vision, we will seize opportunities to support the NHS and patients through innovative data partnerships that fundamentally drive improvements in health outcomes. And then, last but not least, we have health and social care integration strategy. The NHS app will offer a personalised experience for users and encourage them to engage in tailored preventative activity, for example, screening, immunisations and health checks. So you can see very strongly through those strategies, that rhetoric coming through, that we will rely more heavily on data and AI to make healthcare more predictive, preventative, participatory and in so doing, we will improve population health, improve the experience of care, and reduce per capita cost. What you may have noticed is that in none of those statements does it say how we are going to achieve that, i.e. there is no focus on how you're going to do that, through what mechanisms are we going to use, or what tech exactly are we going to deploy in order to bring about these wonderful promises. There are a number of different tools that could potentially do that translational process, but the most well-known or the most widely deployed and therefore the most widely developed is clinical decision support software. Clinical decision support software, if you are aware of the NHS, you probably know, has been in use in the NHS for a long time, since the 1980s. The form of clinical decision support does vary, but the idea is essentially the same. The idea is that a healthcare provider gives the clinical decision support some characteristics of the individual patient. The software matches those characteristics to those stored in a clinical knowledge base, and then that software takes that information and presents the clinician with some form of patient-specific information. To give a very basic example, I am a cisgendered female over the age of 25. If I went into my GP, there's a pretty good chance a little pop-up would appear on my GP screen that says, Jess is a cisgendered female over the age of 25, you should probably remind her to go to cervical screening. Sort of logic underpinning this is that by providing clinicians with the right information about the right patient at the right time, in the right format, in the right channel, this is so-called 5 rights, we can reduce the amount of uncertainty that clinicians are having to deal with at the point of decision making, so we can therefore make them make more consistent and quote-unquote better decisions for that specific patient. And that will therefore result in better quality decision making, more evidence-based, more in line with treatment guidance, more cost effective. But that type of basic form of clinical decision support is not really capable of delivering on the policy promises of AI or of that P4 medicine driven achievement of the so-called triple A. The reasons for that is because traditional CDSS has a knowledge engine that is pre-programmed. So it is basically a large flowchart. If you are more familiar with CompSci, then you will know that this is a so-called expert system. So this is basically a large flowchart saying if this, then that. There's a form of computerized clinical guidelines. It's not really designed to give the clinician any form of new information or present them with any form of new novel types of treatment. It's really just an aid memoir because we're saying clinicians have to remember an enormous amount of information, so we might as well just prompt them to remember something that they already know. It's a one-way knowledge extraction system, so you're really just prompting the system to say, hey, give me the basic guideline for a cisgendered female over the age of 25. There's not really a kind of discursive element to that, i.e. there is no multiple ifs. It will just say, if female over age of 25, remind to do cervical screening. It won't take into account different types of factors. There's no secondary level of ifing going on, and it's presenting information to clinicians in a form of a basic warning and full inference. So we're not saying, if this is likely to happen, then this is supposed to happen. The most important thing is that everything here is linear. We're assuming that we know the relationship between a particular type of patient's symptoms, a particular type of illness, and the treatment. We are assuming it's all one-to-one-to-one. That is not really the type of reasoning that will enable personalized, predictive, participatory preventative medicine. Instead, what the system is really describing when it is talking about the achievement of those goals through making it more data-driven and creating a learning health and care system is the implementation of algorithmic clinical decision support software. So this is where the knowledge engine, rather than being pre-programmed on knowledge that is already known to the system, i.e. clinical guidelines, it is in fact an algorithm, for example, a machine learning algorithm that has been trained on all of the data of all of the patients in the NHS to work out which types of people are most likely to develop this particular type of disease, then to work out what treatments they respond to better under what, and what outcomes are therefore likely to be achieved. It is looking for multiple layered conditional reasoning. So if this, if this, if this, if this, and this, and this, and this, and this, and it is not reliant on there being a linear relationship. Those relationships could be entirely non-linear because a machine learning model is able to handle a great deal more parameters and complexity and funky types of relationships than something that is pre-programmed. The knowledge center is then inferring relevant advice by others. So, for example, if I have a patient that has X, Y, and Z symptoms, what is the most likely diagnosis given these other contextual factors, and given those other contextual factors and the multiple parameters about that patient's, everything from their genetics all the way through to their lifestyle and their economic situation, what is the best treatment for them, and what does that best treatment recommendation rely on? So it's all what if scenarios essentially, and it's highly personalized to that particular patient. Again, if you're nerdy and you want to go and do a bit more reading, this is called case-based reasoning. How many patients have I seen that match these exact types of parameters? What happened when patients of that type were given this type of treatment? And how likely does that scenario match the scenario I'm now currently facing? That information is then presented in a highly inferential way, so it is giving a well-reasoned argument with a form of description, and it is necessarily relying on causal inference. It is assuming that these symptoms that you are now treating are based on these types of factors of that patient, and by treating it we will achieve these specific types of outcomes. So when I say AI for the rest of this presentation, which will almost certainly happen, I mean algorithmic clinical decision support software, and I am primarily talking about algorithmic clinical decision support software trained on data such as electronic health records, rather than image recognition software. A lot of the stuff I will say in this presentation applies to image recognition software too, but that is a slightly different kettle of fish, and we shouldn't merge the two. Okay, so now we have understood why the NHS wants to deploy AI. We have understood what it really means is that it wants to create a national learning healthcare system, so turn the NHS into an NLHS through the implementation of algorithmic clinical decision support software. Elephant in the room. If you are listening to this, you are probably aware that the NHS has a terrible history when it comes to large-scale digital transformation. There are really high-profile failures such as the National Programme for IT, Care.Data, GPDPR, more recently streams in the Royal Free. So the question becomes, how can the NHS be enabled to capitalise on all of these advantages of algorithmic clinical decision support software? So how can it be turned into a national learning healthcare system and achieve the triple aim through the greater reliance on P4 medicine if it has a history of failing when it comes to large-scale digital deployment? Well, the first thing is to understand why it is these types of things have failed. The reason these types of things have failed in the past, there are multiple evaluations that you can go and read that tell you this. I'm glossing over them for the interest of time, but in a nutshell, it's because they underestimate the level of complexity in the system. So there tends to be an assumption that if I take this technology in package A and I incentivize its adoption through policy, then I will achieve outcome B. There is no real nuanced understanding of how the likelihood of that being achieved is affected by the underpinning infrastructure. So, for example, the underpinning railway line upon which we are putting the new train affects whether or not the train is then able to actually run and get to the new destination. It is just assumed that by telling people to adopt the technology, we will get a result. This is a sort of command and control type of thinking that we saw, for example, in the National Programme for IT. It's a really flawed way of thinking, and it would only really work in a very narrow, non-complex system, by which I mean a system that has very few components, very few interacting parts, and we know exactly what happens when those different parts interact. Again, if you're listening to this, you know that the NHS is so far from that. It is composed of hundreds of different components, multiple different organisations controlled in multiple different ways. There are thousands of people involved. There is multiple different types of systems. There is no such thing as the NHS. There is an NHS brand that is across a number of different organisations, and they all interact and work in their own little ways. So the idea that we can just make them all do something in the same way and achieve a definable goal through the implementation of that just by telling them that we want them to implement it is wildly unrealistic. Instead, we need to adopt a logic of design. This is not the same as 1,000 flowers bloom or letting things bottom up. It's instead identifying the system components, connections and constraints, so the form, identifying what are all of the different parts of the system that are involved in the implementation and deployment of the system, how do they interact, and how do different types of interactions produce different outcomes. And which of those potential different outcomes are what we actually want? What is the specific function we want through the implementation of this particular type of technology? And then how can we configure all of those components? So how do we design the system by taking together all of those components in the exact same way that you might design a house in order to achieve a particular goal, i.e. in order to achieve a particular architectural design, that is conceptual design. So I am taking the idea that I want to achieve X. In order to achieve X, I need to take all of these different building blocks, I need to put them together in this particular way in order to achieve the design of Y, and I want to achieve that Y because it enables all of these wonderful things to happen. It enables people to live happily forever after in their house, and that house does everything for them. It's clean all the time, and there's always food in the fridge, and the bathrooms never run out of toilet paper. That is the general logic. To put that into more technical terms, we are saying, what are the information infrastructure requirements? AI is an informational technology, so what are the building blocks that particular informational technology runs on? What do we need them to do in order to ensure S is successfully implemented? And to be even more precise, when I say information infrastructure, I am talking very broadly. I am not just talking about computers. I mean the hardware and the software, clinical content, human-computer interaction, people, workflow and the communications, the internal organisational policies, external rules, regulations and pressures, as well as the system measurements and management. Now, what do I mean by successful? I've said that word about 1,000 times already. I will say it at least 3.5 million more in the next hour or so I should probably tell you exactly what I mean. What I mean by successful is when there have been studies done of what makes technology work in the NHS. There are hundreds of different factors that go from the very minute all the way through to the very macro. When you aggregate them, they give you these four concepts: technically feasible, socially acceptable, ethically justifiable and legally compliant. Now, very, very, very importantly, these are not independent things. In order to achieve success through technical implementation, they all have to be achieved at the same time, and we have to recognize that one influences the other. So technical feasibility influences legal compliance, which influences ethical justifiability, which influences success. And to come back to that question of why has the NHS traditionally failed with large-scale tech implementation, it is because it underestimates those connections between those four things and the fact that we have to think about them all simultaneously. Now we've got to think about how we make sure that this doesn't happen in the future. How to make sure the implementation of ACDSS does not fail. In order to go forward, we have to go backwards. So we've got to think about why our current attempts to implement ACDSS, of which there are several, are not working. If you are in the world of the NHS, I hope you are aware of the NAS framework developed by the always brilliant Trish Greenhalgh and colleagues and the Non-Adoption, Abandonment, Scale-Up, Spread of Technologies framework. It essentially argues that in each of these elements, so condition, technology, value proposition, adopters, organisation, external contacts, adaptation over time, the more complexity there is present in each of those, the more likely technology implementation will fail. To give you a TLDR of what this entire slide says, ACDSS is complex in every single one of these areas, and therefore the likelihood of success is really, 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 really low unless we manage to reduce that complexity in some way. So briefly, condition is complex because rather than trying to take a condition that is well known, we know the symptoms of, we know who is likely to develop that specific condition or disease or illness or whatever you want to say, and we know what the outcomes of the specific treatments are, and we know exactly which variables are involved. With ACDSS, the entire point is to disrupt that. The entire aim is to take diseases and conditions and illnesses that we don't understand the causality of, that we don't know who is most likely to develop from, and that we don't know the most effective treatments for. And we are hoping that the ACDSS will solve that problem for us through that process that I described before. Next, technology. Simple technology is a kind of plug and play type of technology. It doesn't really need to interact with existing clinical systems. It doesn't really need to access patient data. It's just something that we can turn on and off. Upgrading the exact laptop that is used, a particular general practice, that might be complicated because it might require teaching people how to use it, and it might require making the printer work, and we all know that that's the world's worst job, but it is not complex. ACDSS, on the other hand, is complex. It is deployed by design within existing clinical systems, which means it is very vulnerable to legacy issues. If that exact system is not working in the way that the ACDSS thinks it's going to work, it's going to fall over. It is entirely reliant on access to patient data and, importantly, to live real-time patient data. And that introduces a multitude of accuracy and privacy risks. Accuracy because of the whole rubbish in, rubbish out, and privacy because you are giving third-party companies access to the full patient record in order to then get them to predict, etc., etc. Value proposition is primarily about, this is the work of NICE, etc., when they do health technology assessment. What is the evidence base, both in terms of the real-world effectiveness, but also in terms of cost efficiency? Do we know that this particular technology achieves the goal that we want it to achieve in terms of patient outcomes reliably, consistently, and cheaper than the option that we already have? With a clinical decision support software, none of that evidence base really yet exists. There is a thing called the implementation gap, or somebody has called it the model graveyard. What tends to happen is that you get nerdy people like me and my friends, we build a model inside highly elitist academic institution, and then it works brilliantly. We have a high level of statistical accuracy, and then you can deploy it in the real world, and then that whole thing falls down. So the evidence base of these tools and technologies and algorithmic clinical decision support software working in the real world is confused, it's contradictory, it's really limited. You can go and look at a few systematic reviews that sort of demonstrate this. Then we have adopters. We're talking about something that is a simple technology, that is where the value proposition is clear. Therefore, people who are going to benefit from that value really want the technology, and it's a bit of a no-brainer. With ACDSS, this is wildly different. First of all, the willingness to adopt is very conditional. It depends on a number of different factors. Do I know who it was developed by? Do I know value? Do I know how to use it? Is it threatening my job? Do I trust it? On and on and on and on. And there are multiple barriers to those conditions being met. Some of those barriers being that we don't know what all of those conditions are, some of them being that we don't know how to overcome them. So highly complex. Then from an organizational perspective, a simple technology does not really require an enormous amount of reconfiguring how everything works around it. Now with ACDSS, that is not true, because we are asking clinicians to take on new roles, we are asking them to see into the future, we are asking them to give preventative and predictive advice. We are changing the workflow because we are asking people to intervene earlier, but also because we don't know when in the workflow, when in the clinician's decision-making process, is it best to give them the information from a clinical decision support software. And we are involving new third parties, most of which are private third parties, in the NHS directly, because these are live systems, they are updating in real time, and we are therefore handing over a fairly significant degree of power to new organisations, and essentially the whole entire organisation from end to end is way more complex. Then external context. If something's simple, we know exactly how to regulate it, we know who is responsible for regulating it, we know how much it's going to cost to deploy, and we know what social problems we need to overcome. ACDSS is not true. The entire regulatory context, all the way through from software as a medical device, through information governance, through liability, through hundreds of different things, is completely and utterly disrupted and broken. This is not because people are not doing anything about it before you come at me. I know that the MHRA has a plan with regards to a software as a medical device, but it is not there yet. It is changing very, very rapidly, and there are large blocks of regulation that haven't really been considered. The liability one, as in what happens if an algorithmic clinical decision support software gives the clinician the wrong advice, the clinician acts on it, and harm happens to that patient. Who is liable? We don't really know. And so that's an enormous amount of uncertainty for the developers of these technologies and also for the users. We also don't know how much it really costs to deploy these things because, as I said, the value proposition is not clear, and there are numerous social challenges overcoming. We have to think about patient acceptability, we have to think about trust, we have to think about getting people's heads around the idea that they are being diagnosed by effectively a computer rather than a doctor. So there's an enormous amount of complexity there. And adaptation over time. To be clear, in the framework, in the NAS framework, adaptation over time normally means how each of these different factors are shifting over time, as well as a little bit how the technology is changing over time. In the context of algorithmic clinical decision support software, I'm leaning very heavily into the fact that the technology itself adapts over time because that is what we want it to do. It is learning in real time because that is what we want the National Learning Healthcare System to be supported by. It is learning each new case that it is presented with, each new patient goes into its learning, goes into its tweaking. Some of that is happening in a black box and it's entirely ungoverned. And then there are also changes that it is affected by. So for example, if the algorithm was trained on population A and then it was deployed in hospital that was supposed to have population A, but over time that population has actually shifted to population B through, for example, people moving in and out of the area, population drift, that will affect the accuracy of these models, but it might not necessarily be known that that's happening. So there's an enormous amount of complexity there. Current attempts to deploy algorithmic clinical decision support software in the NHS are failing because there is an enormous amount of complexity. Specifically, it is disorganized complexity, i.e. there are multiple different types of factors involved, many variables. We don't know how they interact and we don't know how to control those interactions, hence disorganized complexity. So in order to change this, in order to increase the likelihood of success, we need to reduce the degree of complexity and we need to make it more organized. We need to be able to know exactly which variables are involved, which system components are involved. We need to know how they are interacting and we need to know how to control them. Coming back to this point about design. First, however, before we think about overcoming all of those different complexities, we need to think about why it matters, not just from the likelihood of success of implementation. Now, for a concept from design is consequences that are either intended or unintended. It's an idea called emergence, if you want it to be nerdy. So intended consequences, that's what we want to achieve. Unintended consequences, what we don't want to achieve. At the moment, the level of complexity and the disorganization of that complexity in the system is so high, we cannot predict the output of what we are trying to do, i.e. we do not necessarily know what is going to happen at a systemic level from the large-scale implementation of algorithmic clinical decision support. In order to make sure that we are proactively preventing against those unintended consequences, we need to do something called ethical foresight analysis. So what might happen if we do not control the implementation right, so that we reduce the likelihood of unintended consequences or unintended emergence. That is essentially what I am doing here. I'm taking 3 different types of scenarios that could potentially happen if we do not think very carefully through how we implement these things, i.e. if we do not reduce the complexity in order to make the system more controllable, or if we make the wrong types of changes to the system. These scenarios are all based on the main principles of the NHS Constitution. Scenario 1 is that the patient is displaced from the centre of care. By deploying these systems, we start changing what counts as evidence of illness. Instead of listening to the patient when the patient comes in and says, I am feeling this in my body, we rely entirely on the data. What does your electronic health record plus your Apple app plus your Garmin plus your social media interactions plus what you've been searching for on Amazon tell you is currently wrong with you, and we never speak to you in that process? And then what happens if the algorithmic clinical decision support software takes all of that data into account, turns around and says you're not sick, there's nothing wrong with you, and the patient still says, oh, but I don't actually feel like myself? Who is right? The model, the algorithmic clinical decision support, or the patient? And that really matters because it is much more likely that the algorithm or the clinical decision support software can predict what is wrong with you if you generate high quality data about yourself. I, as a millennial who's obsessed with tech, probably generate hugely good quality information about myself because I have access to all of the tools that drive good quality data. I think obsessively about how I make sure that that data is right, and I have the skills and the digital health literacy to be able to turn around and say to my GP, actually this doesn't really sound right, there must be something going wrong in my record somewhere. Lots of people are not in that privileged position, and so we are changing what counts as evidence of illness. We are also changing what counts as good patient behaviour. This, for the people who want to get into it, is philosophy based on Parsons' sick role. Parsons' sick role is essentially saying that when somebody is a good patient, they fulfill the sick role because they become unwell through no fault of their own, and they are willing to do everything that they can, follow all of the advice in order to become well. That gains them social capital because they are fulfilling the sick role, they are being a good patient, and they therefore incur willingness from the system to give them all of their help. Now, in an algorithmic clinical decision support software environment based on that P4 scenario, we make it pretty impossible for people to be good patients. Because if, for example, we are saying that we are going to predict when people are going to become sick and we're going to give them preventative advice, we are not necessarily taking into account the social determinants of health and the ability of people to actually act on that advice. So give a very boring and basic example. If the advice is you should lose weight, that might not take into account, for example, whether or not that person has the time to get out and exercise. Can they actually afford to buy healthy food in order to reduce their weight? There are multiple factors to do with that. That is a social problem, not necessarily a medical problem. And so then people might not be able to act on that advice, or that advice might actually be incorrectly attached to them. So then what happens if they become ill from the thing that the doctor was trying to prevent? Do we then turn around to them and say, you've become ill through your own fault, therefore you do not meet Parsons' sick role, therefore you are not a good patient, you do not accrue the appropriate level of social capital, and the willingness to treat you has declined? And the third reason then is undermining the right not to know. It's a meta-ethics right. In theory, we all have the right to say, I actually don't want to know what's going to happen to me in the future because it's going to harm my psychological integrity. There's been an enormous amount of thinking about this with regards to genetics and genetic screening, but that thinking has not really been applied to predictive modelling. What happens if, for example, the clinical decision support does predict that you are likely to develop a particular type of condition, but there is absolutely nothing that can be done to prevent it from from happening? Is it right that we tell that person? Does that person need to have access to counselling in order to know that is going to happen? Do they have the right to say, actually, I don't want to be told about things might happen to me that I cannot prevent? Which again cycles through this idea of what counts as a good behaviour and what counts as evidence of illness. The second scenario is that the fundamentals of care are disrupted. In order to understand this one, we have to think through the fact that the fundamentals of caring is based on trust. In order to develop a therapeutic relationship between clinician and patient, in order for patients to be willing to be treated by the healthcare system, this is all based on trust. At the moment, if we do not think through carefully how algorithmic clinical decision support is deployed and what types of infrastructure we need in order to make sure that implementation is controlled, there is a very significant chance of considerably undermining that trust and therefore disrupting the fundamentals of care. The first reason is that we are changing power dynamics. In the history of medicine, there has been a huge shift away from this idea that the clinician is the all-knowing, all-controlling being and that they have more power than the patient. We have done an enormous amount of work to reduce that and to introduce concepts like shared decision-making in order to rebalance that power. With algorithmic clinical decision support, we are reintroducing an omniscient or all-powerful, all-seeing being in the form of an algorithm. So that's first of all changing the power dynamic because it is undermining the power of the clinician and it is giving epistemic authority to a third party that is a private third party developed outside of the system and largely developed outside of health. Then we are devaluing the ethics of care because this is about things like empathy and understanding and semantic understanding, really being human with the patient and what are they feeling and how are they experiencing it. No matter how well something can mimic empathy, it is not the same thing. And we do not yet know really what the consequences of that are. And then there's the challenge of accountability. The way in which we typically govern the healthcare system and the way in which we protect trust is by actually reducing the need for it in the first place, by which I mean by making sure there are so many rules and regulations and so much points of accountability that there is no real need to rely only on I trust you. And we know what to do if something goes wrong. We know who to hold liable, we know how to go back and fix the problem, etc., etc. With clinical decision support, that entire process is disrupted. First of all, we don't really know how to find the source of the problem because there are many parties involved. If an algorithmic clinical decision support software misdiagnoses a person, is it because of the data that was collected that it was then trained on? Is it how that data was curated? Is it how that data was accessed? Is it the design of the model? Is it the way that the model was used? It is the way that the clinician interpreted the model. It is the way that the patient interpreted the advice given to the clinician based on their interpretation of the model, on and on and on and on and on. And importantly, we don't really know how to deal with that scenario when it does happen. As I said, we haven't really thought through the legal aspects of liability. And then scenario 3, the one that I think is really particularly crucial, is that the NHS ceases to be for all. I won't talk so much about bias because I'm sure everybody is aware of bias and the potential for algorithmic clinical decision support software to be biased if we don't have enough patients in the databases that represent the entire population. We will not have algorithms that are capable of diagnosing correctly for every single type of patient. The more important thing is the creation of the inverse data quality law. If you are aware, the inverse care law is essentially that the availability of care varies inversely with those who need it. What I think is happening now in the creation of the inverse data quality law is that the availability of high quality data varies inversely with those who most need it. To put it more bluntly, the people who are more ill and need more help from the healthcare service are the least likely to generate high quality data on themselves. And so we are going to effectively, unless we think about this very carefully, design them out of the system. Those are the unintended consequences that can happen through disorganized complexity because we can't control the system when it is, therefore we cannot mitigate against unintended consequences. In order to mitigate against these unintended consequences and enable the NHS to capitalize on the many benefits of ACDSS, we have to bring that complexity, reduce it, make it more organized so that we can control it, so that we know that if we pull this particular lever, this is the outcome that we are going to get. In order to do that, we've got to think through the requirements. So we've got to think through all of those different system components and how we put them together in order to achieve the outcome. And we need to think about how we deliver those requirements in the first place. In order to make this a little bit more palatable or more accessible, this is broken down into 6 areas that map on to those areas of complexity from the NAS framework. And you will see that in each 6 we go through what is required and how do we deliver it. So to start with information is covering both the training data, the input data, and it is covering the output data. To summarize briefly what we've already heard with regards to information at the moment, input data is largely quantitative, it's error prone, it's missing, it's messy, and all of this can have a negative impact on the quality and the quantity of data. All NHS data is essentially administrative data. It was never collected for the purposes of training models. It was collected to help clinicians remember some things about that particular patient in the moment. And so it is error prone. It is entirely quantitative. It is only based on things that we can measure. It is not based on a person's feelings or their particular preferences. It's plagued by missingness because there are certain types of patients that are not in there. You only generate data of patients who turn up to the healthcare service. We only generate data of events that are triggered. And some people don't like certain things to be recorded. Ethnicity, for example, is missing in about a quarter of all NHS records. Ethnicity is also not a static variable. It changes over time, as there are multiple different ways of defining certain things in the NHS. For example, there's like upwards of, I can't remember the exact number, but something like 15 ways of defining whether or not somebody is in a care. And so that causes messiness. And all of this affects the quality of the data and the quantity of the data available for different types of patients. Essentially, this is a long-winded way of saying we have a massive rubbish in, rubbish out problem. It's also about the output data. Poor user experience of algorithmic clinical decision support at the point of care is likely to result in misinterpretation or damage to the clinician's epistemic authority. People are not given sufficient training, and this all has a negative impact on interpretability. And then to link to that scenario that I was just describing, all of this undermines the system's ability to provide excellent care for all. This will create bad patients, so patients who are not capable of fulfilling pass and sick role, and it will ultimately overly mediate the therapeutic relationship because the clinician is too busy trying to think about what does this system mean more than listening to the patient. In order to avoid this scenario, to avoid the negative consequences or negative re-ontologizing emergence, so the negative transitions, the displacing of the patient from the centre, etc., due to disorganised complexity, we need to redesign the NHS information infrastructure to provide the system with epistemic authority. This is so that clinicians are confident that algorithmic clinical decision support software outputs are valid, valuable, and constructed to improve their capacity to make shared decisions that ultimately lead to better outcomes for their patients. So the vision essentially is we need to provide the system with epistemic authority. How do we do that? So sort of a high level, that means we need to ensure that all those responsible for creating, curating and collating NHS datasets that will ultimately become ACDSS inputs accept their epistemological responsibility. They accept the responsibility that they are creating knowledge for future clinicians, and that will therefore have an impact on patient care. It's not just a case of, oh, I'm going to click this button and record this particular SNOMED code. There are consequences of that further down the chain. All relevant stakeholders must acknowledge the fact that the creation of poor quality, incomplete data sets is an ethical concern and not just a technical problem. And the UX of these systems has to be designed to support and not undermine the cognitive workflows and mental models of clinicians. So we can't just randomly fire information at a clinician and expect them to respond and interpret it if it does not happen in a natural way in that workflow. In fact, if we disrupt that workflow and disrupt the mental model, it's likely that the outcomes will be worse than if we had never provided that advice in the first place. More specifically, in order to provide the system with epistemic certainty, the NHS's information infrastructure, so the components of the NHS's information infrastructure, must combine to deliver consistently good data quality, sufficient data quantity, and reliable data. Moving on to the technology vision requirements. So this is covering back-end and front-end. Back-end, the underpinning hardware and software supporting the development of ACDSS in the first place, such as data access mechanisms, and the front-end, the hardware and software supporting its deployment at the point of care. For example, how it might integrate into an electronic health record. To summarise what disorganised complexity problems we are tackling here and what the consequences of those disorganised complexity problems are, data exchange at the moment between the healthcare system relies on multiple insecure, non-transparent and rarely audited data flows. So data may start off being collected in a GP record, and it is then sent to a processing company who then may send it or give access to a technology company in order to develop an algorithmic clinical support software. That itself will generate data that is then sent to NHS England, who might evaluate it, etc., on and on and on and on. If you're interested, myself and Joe Zhang have a paper that maps all of the NHS's data flows and shows that NHS data flows to upwards of 400 different data points, and those are the ones that can be identified. All of that is highly insecure. It's non-transparent. We don't really know. Most patients don't know what's happening. It's really rarely audited. Legacy technology and poor interoperability hinder the point of care access. So essentially, it's very difficult to implement third-party system components into things like TPP and EMIS, the electronic health record providers in primary care, or to Cerner, one of the record providers in hospitals. The consequences of this, that we might damage psychological integrity because people don't know what is happening to their data, and in an algorithmically driven world, in the case of algorithmic clinical decision support software, patients are their data, because that is determining how their health care is. So if they don't know what is happening to their data, they don't really know what is happening to themselves. That causes damage to psychological integrity. It also undermines autonomy and it threatens trust. And the interoperability and legacy tech issues means that we don't necessarily know how to implement these systems in a way that supports the autonomy of clinicians, which also threatens trust between patient and clinician because they feel as though that relationship is overly mediated, and it's also very difficult to locate and correct breaches. So, for example, if data is breached and privacy issue arises. In order to get over those disorganized complexity problems and to prevent the re-ontologizing consequences, displacing patients from the centre, etc., we have to redesign the NHS's information infrastructure to provide the system with robust information exchange. This is so that ACDSS facilitates the trustworthy and caring exchange of information between patients, ACDSS developers, policymakers, regulators and clinicians on the front line. In order to do that, we need to tweak the different components of the building blocks in the following way. We need to record as much health data as accurately and comprehensively as possible at source without that collecting of data interfering in the consultation. This is to minimize the need for multiple sources of data. We then need to invest in privacy-preserving data access mechanisms to minimize the need to rely on this de-identify and disseminate method. And we need to avoid the creation of further additional silos. In particular, we need to prevent a scenario where the highest quality data is controlled and owned by private third parties who can do with it what they will. To be more specific, to provide the system with robust information exchange, the NHS's information infrastructure, all of the different components must be configured to provide comprehensive user-friendly electronic health records, privacy-preserving data access mechanisms, seamless algorithmic clinical decision support system integration, so making sure things work at the point of care in existing clinical systems, and system-wide protection from vendor lock-in. Next, process. This is talking about all stages involved in the algorithmic clinical decision support software lifecycle, from defining the purpose through to its ongoing impact evaluation. Currently, the problem is that lack of standardization, systematization, sorry about all the Zs, this is my computer being in America, and rigor surrounding the entire implementation process is resulting in a poor quality evidence base. So this is basically linking back to that value proposition point I said. We don't know, there's no standardized way of evaluating clinical decision support. There's no way of validating that it actually works in the real world environment, and the sort of post-market surveillance ideas are thin on the ground. And so there is not a lot of evidence supporting the claims that ACDSS can genuinely deliver improvements to patients and the systems. The consequences of this is we're undermining the concept of informed consent, because if we don't know that these things work, how can we reasonably expect patients to understand the risks and the benefits of ACDSS being used in their care? Also undermining the commitment to patient centricity, because patients, as I have said, are being effectively pushed out of this whole entire scenario. Also undermining the principles of evidence-based medicine, because you can't be evidence-based if there's no evidence, which is essentially harming the ability of clinicians to act on their fiduciary responsibilities as learned intermediaries. They don't know that this stuff that they are using works. And this also means, because there is no ongoing monitoring, that if unwarranted variations in care happen as a result of the implementation of these systems, they might go unnoticed and unfixed. To get over the disorganized complexity, i.e. to get over the lack of standardization, systematization, etc., we need to design the NHS information infrastructure to provide the system with validated outcomes. This is so that ACDSS enables clinicians to uphold and enhance the tenets of evidence-based medicine to ensure all care in the NHS is delivered to an appropriate standard following the best evidence and contextualized to the patient, because that is the full meaning of evidence-based medicine. It's not just the evidence, it is the evidence contextualized to the patient to deliver the best possible health outcome for the specific patient in question. In order to deliver that vision of validated outcomes, we need to bring together all stakeholders to develop procedures, protocols and standards that span the entire ACDSS pipeline and cover everything from best modelling practices all the way through to independent ACDSS evaluation. More specifically, in order to make that happen, we need to bring together the following system components so that the system delivers clearly stated clinical outcomes, mindful model development, rigorous technical validation, rigorous clinical evaluation, careful local calibration, and ongoing impact evaluation. Next, we have to think about objectives and values. This is to do with the principles, the values, and the rights set out in the NHS Constitution that need to be embedded in the technical design of ACDSS and its supporting infrastructure. It is essentially the overall level of disorganized complexity that is posing a threat to the values, as we have seen. It's the disorganized level of complexity that is resulting in potential unintended consequences or unintended emergence that then creates those scenarios where the patient is displaced from the centre of care, NHS ceases to be for all, and we stop providing excellent care, i.e. undermine the values. However, indirect requirements, so as in all of the requirements for reducing complexity and the other ideas, are necessary but not sufficient to avoid damaging impact on the NHS values. Instead, consideration of the impact of the NHS's values have to be built into every single information infrastructure decision. And we also need to ensure that all ACD stakeholders, including third-party private providers, are aware of their importance and how they can be upheld. 4, we need to think about redesigning the NHS's information infrastructure to provide the system with actively protected values. So not just acceptance that they're there, actively, proactively protecting them. This is so that ACDSS not only upholds but protects the core values of the NHS from all trade-offs and dilutions. In order to deliver that, we need there to be explicit commitment from all stakeholders involved in the implementation of ACDSS to the values set out in the NHS Constitution, that it provides a comprehensive service for all, that it aspires to the highest standards of excellence, and that the patient will be at the heart of everything that the NHS does. To provide the system, therefore, with actively protected values, the NHS's information infrastructure, so all of the components of the infrastructure, must be configured to deliver a commitment to the principle of collective provision, a commitment to the principle of patient centricity, and a commitment to high quality care. So staff and knowledge. This is covering the skills required by key staff groups in the ACDSS implementation pipeline to use, govern, analyse the outputs of ACDSS in a way that is safe, effective, and in keeping with the core values of the NHS. Disorganised complexity currently means that clinicians do not receive sufficient training regarding the use of ACDSS, which may also have some black box elements, and this leads them vulnerable to automation bias, i.e. the assumption that the computer must always be right, effectively. NHS analysts and senior leaders might also interpret the outputs of ACDSS inappropriately. So if you remember that ACDSS is not just about the point of care, it is about creating that learning healthcare system. So the outputs, i.e. the aggregate results, if you'd have senior leaders, policymakers, etc., who are not sufficiently data literate, they may interpret those things incorrectly. They may use them to inappropriately surveil staff, for example, and start thinking through, oh, you didn't follow the advice of the ACDSS, that means you're a bad clinician. There may be perfectly valid reasons for not following the advice of an ACDSS. It might be wrong, for example. Or the aggregate results that are suggesting that patients Group A are most likely to benefit from treatment B is based on spurious correlation that nobody has actually gone in and validated. So all of that type of thing is a sort of inappropriate interpretation of the overarching outputs of ACDS. The consequences that are likely to happen is an increase in the rate of EI heterogenesis or harm that happens from information technology, because there's a mismatch between the ACDSS advice and the patient's context. For example, the ACDS recommends that this person do a particular type of activity that for religious reasons or personal reasons it's not possible for that person to partake in, and that is still forced because of automation bias. So the clinician thinks, well, what would be the point in me intervening because the algorithm is clearly right? Or they tell the patient doesn't act on it, and the patient becomes a bad patient, as we have already discussed. That is i.e. heterogenesis, harm resulting from a mismatch between ACDSS advice and patient's context, and ultimately that might result in a worsening experience of care and a consequential loss of trust. To avoid this, we need to design the information infrastructure of the NHS to provide the system with autonomous staff. This is so that the autonomy of clinical staff over their decisions regarding their patients is maintained, as is their confidence to not question their right to this autonomy even when they are using ACDSS. In order to deliver on this vision of autonomous staff, there must be a commitment to maintaining the epistemic authority of clinicians, so i.e. maintaining the right of the clinician to be the person who has the knowledge in order to act on the patient's best interest, taking into account their context, taking into account their professional experience, etc., etc., and making it clear to all stakeholders, including patients, that ACDSS is simply another tool available to aid clinicians to help them keep up with the latest developments in the field to enable more targeted and preventative care. But it is not given any additional status than that. ACDS should not in any way be viewed as a replacement for clinicians or a replacement for any of their functions. To do this, to make sure that the system is provided with autonomous staff, components of the NHS's information infrastructure must be configured to deliver data literate senior commissioners, regulators, policymakers, a highly skilled and appropriately valued analytics workforce, and clinicians with the confidence to protect their epistemic authority. If some of these things sound strange, like data literate senior commissioners, remember that information infrastructure is not just about the wires and cables. This is the last one, hooray! Management systems and structures. This is covering essentially all of the things that govern the system. Information governance regulations, procurement and commercial partnership regs, medical device regs, as well as clinical and safety governance regs, liability and consumer protection regs. Disorganized complexity means that all mechanisms associated with process accountability, so how we make sure that all aspects of the process are accountable, repeatable, etc. Struggling to keep pace with the development of ACDSS. I've already mentioned the liability problem. Medical device regs are really out of date in this context. The consequences of this is that, as I described in that scenario modelling section, process accountability is a prerequisite for building trust and relationships between clinicians and for patients and the public viewing the healthcare system as legitimate. So disruption to process accountability may result in the decline of the healthcare system. To avoid the disruption to process accountability through the fact that the NHS's information infrastructure is currently fraught with disorganised complexity, and to ensure that ACDSS is safe and effective, the information infrastructure needs to be redesigned to provide the system with meaningful accountability. This is so that ACDSS implementation is supported by a proportionate governance framework that guarantees ACDSS developers, deployers and users are meaningfully accountable to patients and the public for the software that they implement. In order to do this means that we need to develop a principled proportionate governance that is appropriately adaptive, flexible, inclusive, reflexive and responsive, and ensures responsibility for patient safety is imposed on all stakeholders involved in the development, deployment and use of algorithmic clinical decision support software. To be very specific, in order to deliver the system meaningful accountability, the components must be designed to provide fit-for-purpose information governance, clearly regulated medical devices, clinician and patient protection, and ultimately auditability. Okay, so now we know what the vision requirements are, and we know what the system needs to deliver in order to meet those vision requirements. Now we need to assess whether or not it is likely that those requirements are going to be met by current policy design. So just as a quick reminder, I'm just going to click through and you can pause the screen if you need to. The information requirement is epistemic certainty. The technology requirement is robust information exchange. The process requirement is validated outcomes. The objectives and values requirement is actively protected values. The staff and knowledge requirement is autonomous staff. The management systems requirement is meaningful accountability. Okay, so how likely is it that these requirements will be met by current policy? So at the moment, with regards to information, policy is relatively limited in this area. Data quality is quite narrowly defined and consistency receives limited attention. By the way, I'm just saying policy, if you want the full list of all of the policies that I evaluated, there's over 70 of them. I will make sure that there's a list available online and I'll put it in a link for wherever this video is. Data quantity is presumed to be about creating larger data sets rather than thinking about what quantity means from a more meaningful perspective. So it's just about having more data points, but not whether or not those data points are the most useful. Data interpretability is very rarely mentioned in policy, apart from occasionally explainability. Technology, recognition of there needing to be robust information exchange is implicit in current policy, but it's not really explicit. There's no meaningful acknowledgement of the need to create user-friendly electronic health record designs. There is a considerable focus on privacy-preserving data access, for example, the regional secure data environment policies, and through innovations like Open Safely, which, if you don't know, conflict of interest development I was involved with up until about a year ago. There has been a lot of progress in that regard, but we don't necessarily know that those privacy-preserving access mechanisms are helpful or hindrance for algorithmic development, for machine learning. They're also hard to use, therefore there are some antibodies with regards to that, and they don't preserve privacy for all types of scenarios. There are then issues of interoperability and vendor lock-in, which are really insufficiently addressed. There is a really big, with policy having a tendency to be attracted to the shiny, to want to focus exclusively on buying new shiny things, deploying, implementing AI, but not going back and fixing the boring. The boring, unfortunately, is where there are issues of interoperability and vendor lock-in, and we are creating new problems of vendor lock-in, things like the federated data platform. So user needs and clinical outcomes are presumed to be the same, which they are not. Policy almost always to user needs. Have you identified your user need? Have you identified your user need? That comes up loads, which is great, but it's not the same as a clinical outcome. It's not the same as saying to clinicians, what is the clinical problem that you would want me to solve? What is the most difficult clinical situation that you are faced with that we could potentially solve through the use of algorithmic clinical decision support software, and what would be the clinical outcome for the patient and for you and for the system that you would want to be achieved through the implementation of that algorithmic clinical decision support software? It's a vastly different question to say, what is your need? I need to be able to access an electronic health record or the point of care. Not quite the same thing. Similarly, there is not an awful lot of consideration about mindful model development. You don't tend to see in policy at the moment, and by policy I mean also enforceable policy, by the way. So there tends not to always be enough focus on standards with regards to how do you think about what particular parameters are included in a model, what are the considerations that go into that process? Are we just doing a sort of throw spaghetti at a wall type of model, or are we thinking about whether or not it is actually useful to have those parameters in a clinical model, and what might be the implications for the patient if those parameters are included? Whilst there is a high level recognition of the need to validate and evaluate algorithms, it's quite limited. It tends to just be statements that say you should do validation and evaluation, but not an awful lot of thinking about the how, and definitely not about providing the infrastructure in order to enable that how. And there is really limited recognition of local calibration. Objectives and values, there is some recognition of committing to quality care, but it's very high level. There is very limited recognition of the commitment to collective provision. You'll get references to the need to think about bias, but not really think things really deeply, like that concept of the inverse data quality law. And there's a really high degree of over-reliance on policies that extol the benefits of transparency and fairness, which is assumed to be the same as trustworthiness, which it is not. Staff and knowledge, I would say that this is one of the areas in which policy is doing relatively well. There is recognition of the fact that there is a need to upskill senior leaders. There is a detailed plan for upskilling and rebranding the analytics workforce, but there is limited direct recognition of the need to protect clinician epistemic authority. Whilst there are many really great initiatives coming out of things like what was Health Education England, the sort of next level thinking of protection against automation bias, against the legal components of that, against how you interpret that, how you turn that into like templates for outputs of algorithmic clinical decision support, is not really that. And then management systems and structures. This is the area that I think is currently the poorest, because the efforts to develop sufficiently robust governance mechanisms in the form of regulation and standards and things that have actual teeth as opposed to high-level nicey statements, is that there is currently this overarching assumption we must be light touch with regards to regulation, otherwise it might stifle innovation. So there is a need for some course correction. If you want to go in and look in the text, all of those gaps have a quantifiable element to them, but the average comes out at around 6.5. The gap goes between 1 and 10, 1 being no gap at all, 10 being polar opposites, which means it's a moderately sized gap, reasonably unlikely that all of the ideal and delivery information infrastructure requirements will be met. But it is not insurmountable and it can be closed. But in order to close it and think about what requirements might be needed in order to close those gaps, we need to think about why those gaps exist in the first place. And the main reason is that there are 4 assumptions that are underpinning policy, and these assumptions come from, as you'll see in the next slide when I get there, the technical epistemic community. So the technical community, which has an outsized influence over the development of policy, as compared to the sort of social science clinician epistemic community. So the difference, for example, is that policy assumes that the creation of a national learning healthcare system through the implementation of ACDSS and via P4 medicine and the so-called achievement of the triple aim is a first order change. It's an instance of incremental changes to specific aspects of the information infrastructure, but it's not resigned to the core operation. The vision and delivery requirements are based on the assumption that what is required is second order change, alteration to the system's basic governing rules that shift the whole system irreversibly to a new paradigm. The second policy assumption, based on the technical epistemic community's assumption, is that the possible is the same as plausible, whereas the design and the vision requirements are based on the assumption that the possible is not equivalent to the plausible. So what might be possible in the future is not necessarily plausible now. Then the third policy assumption is that the relationship between information and action is direct and linear. I present you with this piece of information, you automatically interpret it correctly, you automatically take the action that I want you to. The vision and design requirements are based on an assumption that the relationship between information and action is not always straightforward. Humans are human. The way in which we interpret information is based on a wide variety of really complex psychological factors that we have to design in order to maximize. And the fourth policy assumption that all regulations stifle innovation. The second part of that is that innovation is an automatic good, whereas the design and the vision requirements are based on the assumption that smart regulation is a necessary prerequisite to adoption willingness. So people need to feel safe. They need to feel that the technology they are developing is usable, it is effective, that if something goes wrong, they're going to know what to do about it, etc., etc. So actually, regulation provides a safety net which increases willingness to adopt. So as I briefly said, those assumptions come from different communities. And these different communities have different expectations of what they want to achieve through the implementation of ACDSS. The NHS experienced scientific community tend to say that what they want from ACDSS implementation is a filling of the communication gaps between different NHS organisations, ensuring clinicians and patients have access to the rich information about themselves, their history and their preferences, importantly their preferences at the point of care, and providing clinicians with access to real-time advice for very specific decisions. Not just providing advice for advice's sake, but when there is a genuine information gap, they want to know, and they want the ACDSS to fill that gap. In contrast, the NHS newcomer, these are the people who build the models, think that what we want from ACDSS implementation is algorithmic screening and predictive wellness, so constantly nudging people build towards thinking that health is a forever ongoing improvement activity, that if you just take one more step, you'll be closer towards, but you will never quite achieve, and algorithmic screening constantly for any potential risk factors, and that we should have closely monitored frontline services, by which I mean surveillance of the performance of clinicians. Now, the problem is that, as I mentioned, this community, the NHS newcomer technical community, at the moment have a greater influence policy design for this particular area than the NHS experienced scientific community. And there's a recursive relationship that develops. So strategy gets released, that gets turned into policy. Policy goes out and seeks expert opinion on how to deliver the strategy goals. That gets people into the epistemic community membership. They influence policy, which then influences strategy. It becomes recursive. So if the strategy is influenced by the techies rather than the NHS experienced scientific community, then they have greater influence over the strategy, policy design, then they become the expert, implement and act on that policy, etc., etc. It becomes self-reinforcing, and the people who are maybe more experienced than the NHS but have less experience of the technical design, for example, they don't build algorithms but they are very, very well aware of the overarching nature of the healthcare system, get left out of that conversation. So the basic problem is that at the moment, the delivery and vision requirements are unlikely to be met by current policy because the epistemic technical community has a greater influence than the scientific community, and there is a fundamental disagreement about the function of a national learning healthcare system enabled by ACDSS implementation between those two communities. In order to overcome that problem, in order to increase the likelihood that policy will make the vision and delivery requirements come into being and how to do that, we have to get to a point of having an agreed unified function. So agreement between all of these different parties about what it is that we actually want to achieve. We need to also make sure that that function negates those negative assumptions. So for example, it negates the assumption that the relationship between information and action is automatic. Okay, first, we have to challenge the assumption that there is an automatic relationship between information and action, and that therefore more information is always better. In order to challenge that assumption, the unifying national learning healthcare system function must have a narrow theory-informed scope focused on getting the basics right. It must avoid giving the impression that more information is always better. It must avoid implying that ACDSS will always result in better outcomes for all, and it must be grounded in the theory of evidence-based medicine and agile software development, i.e. it must always be grounded in a theory that evidence is good when it is contextualized, and that there must always be a degree of iteration. Second, to challenge the assumption of first-order change, we must design a function based on the idea that we review and reassure, we don't dictate. So we must have a national learning healthcare system that avoids making the role of the clinician as a learned intermediary null and void. We must position ACDSS as one element of a much larger whole. It must be something that can be built up slowly over time. It must always keep the patient in the loop. It must focus on recommendations and second opinions rather than decisions. And it must be intended to support clinician competence rather than undermine it. Thirdly, we must challenge the assumption that we always need innovation-friendly regulation, and instead we need regulation-friendly innovation. So the national learning healthcare system function must rest on the principle of first do no harm, be tied closely to use cases for which there is a clear, robust evidence base, and avoid implying that ACDSS is not interventional. It is interventional. There's no such thing as sticks and stones may break my bones, but words will never harm me in the case of algorithmic clinical decision support software. So, taking a function that meets these requirements in order to negate the assumptions that are currently preventing the design of policy that meets the delivery and the vision requirements, the functions that are acceptable to clinicians, patients, and system managers are, first of all, improving the utility and usability of relevant NHS information at the point of care, improving the trustworthiness of information used to inform shared decisions about care, and improving the evidence base and effectiveness of information used to inform public health and service planning decisions. If we put those all together, unified acceptable function of an ACDSS-enabled national learning healthcare system is an ACDSS-enabled NHS should maximise the utility, the usability, the efficacy and the trustworthiness of existing NHS information for the purpose of meeting clearly identifiable information needs rather than information wants. An information need has a clear information purpose. We know why that piece of information is needed at that specific point in time for that specific purpose. And we know that that information, when it is available, contributes to the achievement of a specific purpose, i.e. where there is robust scientific evidence demonstrating its efficacy in meeting the information purpose. Finally, we get to the implementation requirements. So we now know what the vision requirements are. So that's the epistemic authority, robust information exchange, autonomous staff, etc. We know what the delivery requirements are. That is things like sufficient data quality, consistent data quality, sufficient data quantity, reliable data interpretability. We know what the function requirements are, which is utility, usability, effectiveness, and trustworthiness. And so now we just have to think about how do we actually implement those requirements. So what does policy need to do in order to bring them into fruition? And we also need to map these back to the success requirements, so that was technically feasible, socially acceptable, ethically justifiable, legally compliant. To start with user, I'm just going to read what's on the left. This is stuff that's already known. The stuff on the right, I'll read the bold, but you can pause the screen and read the text if you want to. In order to ensure ACDSS implementation is technically feasible, the supporting information infrastructure must be designed to maximise the usability of existing NHS information for specific information needs. This requires designing the information infrastructure that provides the system with robust information exchange. In turn, this requires designing information infrastructure that delivers UX-focused electronic health record design, privacy-enhancing data access, seamless system integration, and protection from vendor lock-in. In order to do that, policy must focus on standardizing electronic health record templates, enabling model-to-data approaches to algorithmic clinical decision knowledge algorithm development, mandating compliance with interoperability standards, combining algorithmic clinical decision support with audit and feedback. So ACDSS should not only provide advice personalised to the patient, it should also personalise the advice to the clinician. We should basically be auditing whether or not it actually works, and mandating modular design and local customisability of ACDSS. Next, ensure that ACDSS implementation is socially acceptable. The supporting information infrastructure must be designed to maximise the utility of existing NHS information for specific information needs. This in turn requires designing information infrastructure to deliver consistent data quality, sufficient data quantity, and reliable data interpretability. To do this, policy needs to value data work, make explainability a standardized ACDSS requirement, and position clinicians as the originators of ACDSS demand. So basically, we should not just be having a scenario where techies want to build a thing because they can and because the data is there. The impetus to build an algorithmic clinical decision support software, add a new module to it, make it do a new function, should always come from the clinicians on the front line. Next, to ensure ACDSS implementation is ethically justifiable, the supporting information infrastructure must be designed to maximise the trustworthiness of existing NHS information for specific information needs. This requires designing information infrastructure that delivers commitment to collective provision, commitment to patient centricity, commitment to quality care, protection of clinician epistemic authority, valued informatics workforce, and skilled leadership. In order to deliver on this, policy must focus on ensuring that ACDSS is built by teams with diverse skills and lived experience, that it mandates the involvement of patients and publics in ACDSS development, and that it pays equal attention to qualitative health information as it does to quantitative health information. It must also think about policy that ensures the protection and encourages provably trustworthy relationships, that it establishes a technical buddy system, it solidifies the NHS Analytics Workforce Statement, and it protects the clinician's right to override decisions made by ACDSS if they disagree. Next, to ensure ACDSS implementation is legally compliant, the supporting information infrastructure must be designed to maximise the efficacy of existing NHS information for specific information needs. This requires designing information infrastructure that provides the system with validated outcomes and meaningful accountability. This requires designing information infrastructure that delivers clear objectives, mindful model development, rigorous technical validation, rigorous clinical evaluation, careful local calibration, ongoing impact evaluation, fit-for-purpose IG, regulated medical devices, clinician and patient protection, and auditability. Oh, that says audibility. It should say auditability. In order to do that, policy must require HTA and NSC review. So require ACDSS to be subjected to Health Technology Assessment and National Screening Committee review. It is providing the same function as a national screening programme, therefore it should be subject to the same standards. That policy provides guidance on model development and feature selection. That's linking back to that point I made before about when is too much too much. Centralises and streamlines and testing and reporting, so that we are not surveilling clinicians all of the time, and ensures oversight of ACDSS implementation and use, so we know it's being used correctly. Policy must also restore process accountability, mandate documentation of all decisions, simplify data ownership, controllership, use case and consent, and require all algorithmic clinical decision support software to be classified as software as a medical device and reported properly. So, finally, we come to the end. A successful algorithmically enhanced NHS requires the implementation of algorithmically clinical support software. That requires an information infrastructure that is technically feasible, ethically justifiable, socially acceptable, and legally compliant. In turn, this requires ensuring that the NHS's information infrastructure is designed to maximise the usability, trustworthiness, utility and efficacy of existing NHS information to meet specific information needs. To meet those requirements, we must design the information infrastructure to provide robust information exchange, actively protected values, autonomous epistemic certainty, validated outcomes, and meaningful accountability. This requires taking delivery actions such as user-friendly electronic health records all the way through to auditability. And that in turn requires policy that is focused on electronic health record design templates, model-to-data ACDSS development approaches, interoperability standards, all the way through to public documentation. You can pause on these slides if you need to. And that is the end. In essence, to get algorithmic clinical decision support into the NHS in a way that is technically feasible, socially acceptable, ethically justifiable, and legally compliant, we need to design the information infrastructure in order to deliver everything from epistemic authority through to actively protected values. And we do that by thinking through every single aspect of the system, all the way through from electronic health record template design, right the way through to process auditability. And that is how we achieve success. Thank you.